Good day, everyone. I'm Kiko Cortez from the UP Philippine General Hospital, here to present our study on the simultaneous correction of Coxa Vara and Panfemoral shaft deformity in a patient with Osteogenesis imperfecta. OI is a rare genetic disorder causing abnormality in type 1 collagen production, resulting to bone fragility and a characteristic symptomatology. Surgical treatment mainly consists of realignment osteotomies and intramedullary rodding to correct the deformities and decrease refracture rates. However, in 10% of cases, a concomitant Coxa Vara occurs, which is defined as a neck shaft angle of less than 110 degrees and results in altered biomechanics of the hip joint, causing complications as listed. We present a case of a 13-year-old female who initially consulted at our institution for fracture of the left tibia. On physical examination, she had short stature, blue-tinged sclerae, opalescent teeth, and bowing of her left leg. She underwent corrective surgery 3 years prior to this consult. Aside from the presence of a shaft deformity on the left femur, she had a neck shaft angle of 80 degrees on the left hip. Thus, our question, how do we address both deformities? First, we identified the chorus and measured the magnitude of each deformity. The femur was traced on paper and the intended osteotomies were marked. A subtrochanteric valgus osteotomy with a magnitude equivalent to the desired correction was outlined to achieve a neck shaft angle of at least 110 degrees. Distally, a single osteotomy parallel to the joint line was also outlined. The three main fragments were cut and reassembled to approximate the gross appearance of the femur after the osteotomies and implant placement. At surgery, the previously placed rods were removed through the previous skin incisions. The level and orientation of the osteotomy were ascertained through intraoperative imaging. A valgus subtrochanteric closing wedge osteotomy was done and a 5 mm drill bit was advanced retrogradely from the osteotomy site to the greater trochanter. Through this new entry point, a 5 mm rod was inserted antegradely to the femoral shaft. A 2 mm drill bit was used to make an anteroposterior hole 2 centimeters distal to the osteotomy site. A 0.9 mm circlage wire was inserted through this hole and fashioned into a figure of 8 configuration with the proximal loop hooked over the greater trochanter and anchored on the bent tip of the rush rod. Stability was checked with range of motion of the hip under fluoroscopic guidance. Another retrograde rod was inserted in a sliding rod technique to stabilize the distal corticotomy and account for the remaining growth of the patient. Post-op, we were able to achieve a neck shaft angle of 110 degrees. The overall alignment of the femoral shaft was also improved with osteotomies and insertion of sliding rods. Patient was put on a double hip spica cast and referred to pediogenetics for pamidronate infusion. The hip spica was maintained for 12 weeks until with adequate callus formation on the osteotomy sites. At 6 months, the patient was able to stand independently and ambulate with the aid of a walker. There is also good maintenance of the alignment of the proximal femur and femoral shaft with good healing of the osteotomies. At 1 year follow-up, patient was able to ambulate independently and participate in school activities. The alignment of the proximal femur and femoral shaft was also maintained. No implant deformity or cutout and fractures were noted. Several authors have described different techniques for treatment of Coxa Vara, which include corrective osteotomies, fixation through the femoral neck, and bone grafting. Based on our literature search, none of them describe it for simultaneous correction of Coxa Vara and shaft deformity. Our technique also obviates the need for iliac crest bone grafting and fixation through the femoral neck. Furthermore, the total cost of the implants used in this fixation is only $20, utilizing locally available implants. In summary, allow me to share some pearls to improve outcomes with this technique. First, insert the biggest possible rod antegradely to counter the deforming forces on the proximal femur. A smaller rod will eventually bend and cause recurrence of the varus deformity. Prepare different sizes of rods and decide intraoperatively to maximize canal fill. Second, enlarge the distal canal to accommodate a retrograde rod, especially in growing children. Finally, the magnitude of the valgus osteotomy should approximate the desired magnitude of correction. Overcorrection by 5 to 10 degrees should be done in anticipation for loss of reduction or progression of the deformity as the child grows. Thank you for your kind attention.